Everyone. The next speaker for today is Dr. Krupa Varughese. Dr. Krupa is an UG and PG alumnus from CMC Velo, and she works as a consultant in general medicine at the Madhipura hospital. And today she will be speaking on snakebite management at Madhipura.
Hi, good morning. I'm Krupa, a physician working in Madhipura Christian Hospital, Bihar. I'm thankful to God and my teachers for giving me this opportunity to talk about snakebite management in Madhipura on this platform. This year, since CMC is drawing attention to many inequities in healthcare, it's only fitting that we talk about snakebite envenomation that claims around 58,000 Indian lives per year, leaving many more suffering lasting mental and physical disability, of which large majority are young adults and children. As Kofi Annan rightly mentioned, it's a public health crisis we have never heard of. Because of lack of advocacy, it's largely an overlooked disease affecting population living in some of the poorest rural communities who have accepted their fate over the years. As clinicians, it's our responsibility to advocate for a disease that is largely preventable but has been claiming an unacceptable number of lives. I take this opportunity to introduce our hospital and the work it does, and also to raise awareness regarding different challenges that we face in a rural hospital in the hope we can work together to decrease the mortality associated with snakebite envenomation in India. We get to see and hear many heartbreaking stories of victims of snakebite. From the story of the 8-year-old Lata, who came to us with an alleged history of bite, which she claimed was a rat bite just before she became unconscious. She had developed respiratory distress for which oxygen and nebulizations were started in the outside hospital. Unfortunately, she was brought dead to a hospital, having gone from hospital to hospital without receiving ASV or critical care support. And the story of the only son, Arun, who was brought dead to the hospital, was perfectly all right before he went to sleep at night, but woke up with abdominal pain, nausea, and breathing difficulty. But unfortunately, he also couldn't reach the hospital in time due to the lack of transport and finances to pay for an ambulance. Parents accepted their fate as their bad luck and not wanting to relocate the snake which they caught due to the fear of curse from the snake. We also hear stories of a lot of asymptomatic patients who come very anxious, who rush to the hospital, scared and stressed. One of those patients were a 2-month-old child who was brought to the hospital since his mother, whom he was sleeping with, was bitten by a snake and had passed away in the hands of a traditional healer 2 hours ago. But they wanted to take the only male child she had to hospital because they didn't want to lose him because he was a male child. But we are very glad to have helped many men, women, and children who come at least just in time, and some even in respiratory arrest, who gets resuscitated and goes from the hospital, thankful having received the right treatment. So keeping this in mind, my focus of my presentation would be to introduce to you the risk factors and outcome determinants of snakebite envenomation in our community, management of snakebite envenomation in MCH with its challenges, addressing some of the antivenom issues, initiatives to prevent snakebite deaths, and novel approaches to reduce snakebite envenomation. Bihar has the third greatest snakebite deaths in India. So we live in Madhipura, which is a northeastern part of Bihar, where the absolute risk of dying from snakebite is 1 person before the age of 70 years. Madhipura is marked in red in this map. Madhipura Christian Hospital is serving the community as a secondary level 100-bedded hospital with 8 ICU beds equipped with ventilators, dialysis machine, echo, and POCUS. We also encounter snakes in our daily lives. However, the encounter has greatly reduced reduced over the years. This was one of us holding up 2 big cobras. Probably at this time, he was unaware that dead snakes can also envenomate. Why is there so much of disproportionate suffering in rural India? Because unlike urban India, whose encounter with snake is minimal, rural India encounters them amidst their daily lives. It's an occupational hazard for them due to non-mechanized farming, barefoot farming, increased farming activities during monsoon season, which puts them at a greater risk of snake bite. It is a domestic hazard as their homes are constructed very near to agrarian fields with no walls and protection. They have poorly constructed house with only one room, if at all, with no separation of kitchen and bedroom and no inbuilt toilets, putting them at a risk of snake bite during their daily chores. After getting bitten, we hear many stories about the reason for delay in presenting to the hospital, such as visiting traditional healers, lack of transport, roads, poor accessibility, railway crossings which they have to wait at, which stands as a tall barrier between them and the hospital. Added to all this are some socio-cultural factors like snake worship, fear of curse from the venomous snakes. This story actually happened in our district in Madhipura, where a young religious man who posed as Lord Shiva with a cobra wound around his neck got bitten by the snake on his neck. He was taken to the hospital nearby. However, due to lack of ASV at the center, he was referred to another center and died en route to the next one. So we had around 250 snake bites patients in 2023, with 30 with features of neurotoxic envenomation. We had 2 deaths related to snake bite. Both of them came very late to the hospital in cardiorespiratory arrest. And we managed to revive them, but they eventually died in hospital. We used to have many broad dead patients due to snake bite. However, it has reduced over the years. So most of our snakebite victims come in monsoon season when the agricultural activities and breeding season of snakes converge. One of the peculiarities of Madhipura is that we see only neurotoxic envenomation. We do ask for WBCT and for bleeding manifestation. However, we haven't come across a hemotoxic bite in the last 4 to 5 years of our experience in Madhipura. In a way, it comes as a blessing to us because in our setting, a transfusion and dialysis would be a bit more challenging than intubating and ventilating the patient. Some of the major outcome determinants that we have found in our setting is delay in reaching hospital and not presenting to the hospital at all. ICMR study has revealed that only 30% of snakebite victims actually reach the hospital, and 80% of the death actually occur prior to coming to the hospital. Reaching the hospital in a motorbike ambulance in less than 1.5 hours was found to have a favorable outcome in our setting. Also, another major delay for our patients to reach the hospital is visiting traditional healers. Around 90 to 95% of patients go to a traditional healer, where the traditional healer usually gives them flowers or leaves to distinguish venomous and non-venomous snakes, and chants and prayers are offered, along with various ways to suck the venom from bite site is also practiced. So how do we manage snake bites? So we teach our communities to offer first aid. So WHO says that every time you have a snake bite, do it right. So first step is to move the patient away from the snake to a safe place and reassure them, since most bites are non-venomous bites. As you may know, 50% of bites by venomous bites actually envenomate the patient. The next step is to immobilize the limb with materials that is available locally, as you do to a fractured limb, and then get to the hospital immediately and tell the doctor of any systemic symptoms that manifest on the way to the hospital. We remove rings and anklets from the bitten limb, since local swelling is common. Irrigate eyes with copious amount of water if eyes are exposed. So there is a lot of debate about usefulness of pressure immobilization. And even though there is no good quality evidence, one systemic review and another done in Myanmar in 15 patients has shown pressure immobilization to be an effective mode of first aid in patients presenting with elapid envenomation as well as Russell Viper's bite envenomation. However, the practicality and the efficacy has not been proven in the Indian setting. So in our setting, since most of them end up coming like this patient in the picture, we educate a patient to not to apply tourniquet, since there can be worsening of soft tissue necrosis due to concentration of cytotoxic effects of venom or ischemia due to vascular compromise. Also, we ensure an IV access and then only release these tourniquets if needed, along with the ASV administration in venomous bites, since there can be sudden clinical deterioration after release of tourniquet. So as soon as the patient is brought to us to the hospital, we assess vital parameters, we check airway, we check pattern of breathing, circulation, and initiate resuscitation if the patient is clinically unstable with shock, paralysis, or respiratory distress. We intubate if there is acute respiratory failure, low GCS, neck muscle weakness, stridor, difficulty to maintain airway. There is no role of starting only oxygen therapy in a snakebite envenomation, since it's a type 2 respiratory failure. So if one is in a primary hospital where there is no facility to ventilate the patient for any reason, we can ensure good bag and mask ventilation till adequate help arrives. Or do intubation and then do bag and mask and transfer the patient. Also, laryngeal mask airway is also another option which can be used along with bag and mask ventilation. If that is also not available, we can use a mask with harness and ambu the patient till we reach the nearest hospital where facilities are available to intubate. However, referring a patient in acute respiratory failure should not be done without protecting the airway. So we reassure and clinically admit stable patients. We get a thorough history regarding symptoms, bite, and circumstances of bite, which helps us in inferring likely biting species. So history of substance abuse and ethanol is important, as it can modify interpretation of presenting symptoms. History of comorbidities like coronary artery disease, chronic kidney disease, and seizures is very important, as it can worsen with envenomation. Also, drug history is important, especially the use of antiplatelets and anticoagulants, since it can interfere with WBCT test. So if a patient, especially children, who doesn't present with a definite history of bite, but who has a nausea, abdominal pain, weak thready pulse, who especially comes in the middle of the night with a cardiovascular collapse, unconsciousness, respiratory paralysis, bleeding manifestation, when there is no prior comorbidities, we keep differentiation of snakebite in the back of our minds. So for examination, we take a close look at the bite site for any retained fangs, tourniquets, incision, and contamination. We look for cytotoxic local reactions and signs of coagulopathy and neurotoxicity. So we assess for descending paralysis, descending afreflexive paralysis. That means the patient might not be able to verbalize or open eyes fully, but may be able to communicate with hands and move the limbs. So we look for ptosis, we look for drooling of saliva, we look for dysphonia and bulbar function. We also assess respiration using single breath count, which normally is more than 30 seconds, breath holding test, which is normally more than 45 seconds, and neck holding test. So we ask them for any video or photo of the biting snake, which helps us to streamline our care. So we use an algorithm which includes a history examination to infer biting species. So this is the algorithm that we use. The snakebite with neurotoxicity and no local reaction, and which the bite typically happens at home with features of some abdominal pain and vomiting, is considered to be a crate bite. The neurotoxic envenomation, mostly occurring in the fields with local cytotoxic reaction, is considered to be cobra bites, whereas the patients with local reaction, coagulopathy, and some neuroparalysis from a snake that bites predominantly while patient is outside in the field or taking some dry leaves from the ground is considered as viper bites, whereas a patient presenting with coagulopathy with no neuroparalysis and having some local reaction can be an undifferentiated viper. So if a patient has history of snake bite or an unknown bite or have a fang mark, but no obvious signs of local or systemic envenomation, is it okay for them to go home? No. Ideally, they should be kept for observation for around 24 hours. So signs of envenomation can appear as early as 15 minutes in a viper bite, or as late as 16 to 24 hours in crate bite. Hence, we have to observe all patients who come with snake bite for 24 hours. So according to the protocol, in places where there are hematotoxic bites, WBCT should be repeated every hour for 3 hours and 3 hourly for the next 3 times and 6 hourly till 24 hours till the patient goes home. So for WBCT, we can use clean, ordinary clean glass tube or ordinary glass bottle, like an antibiotic vial, which is washed with NS. We do not use plastic, polystyrene or polypropylene tube or glass tube clean with detergent, as it can lead to false positive values. So all patients who are asymptomatic are given counseling regarding prevention and first aid management before they are discharged from the hospital. So if there is any, meanwhile, if there is any clinical evidence of neurotoxicity, hypotension, arrhythmias, bleeding, capillary leak syndrome, or a laboratory evidence of systemic envenomation, that is a deranged WBCT test with an unstable clot or no clot formation, or a deranged PTINR, or thrombocytopenia less than 1 lakh, we administer 10 vials of anti-snake venom in dextrose solution or NS, which is given over 30 to 60 minutes after administration of 0.25 mg of adrenaline given subcutaneously. So a study done by De Silva et al., which proved adrenaline decreased acute adverse reactions by 43%, also showed that the hydrocortisone and avil can negate the effects of adrenaline for prevention of anaphylaxis. So we give only plain adrenaline before giving ASV. So in case of cobra bites, neurotoxic bite with local reaction, or a snake bite likely to be cobras but not needing intubation, we also give a neostigmin 1.5 mg stat and with atropine 0.6 mg. So this will be followed by neostigmin 0.5 mg and atropine 0.6 mg every half an hour for 5 doses. If unsure of the biting species, we administer only 2 doses and look for response. We do not administer further if there is no response to neostigmin and atropine. So what is response? Response is taken as usually 50% improvement in ptosis in 30 to 60 minutes. So patient is further monitored for any signs of worsening or persisting neurological deficit. So in case if there is persisting or a worsening neurological deficit, or a spontaneous bleeding, or a persistent shock at the end of 1 to 2 hours, we administer 10 more vials of ASV after giving another dose of subcutaneous adrenaline. Also, we also monitor for early adverse reactions which occurs due to ASV administration. That is an anaphylactic reaction or a pyrogenic reaction. So anaphylaxis, first medicine to give in anaphylaxis is adrenaline 0.5 mg intramuscularly, which is repeated every 5 to 10 minutes till the hypertension resolves. If after 2 to 3 doses, the hypertension doesn't resolve, then we need to start an infusion of adrenaline. So meanwhile, we stop ASVs, we give IV fluids, ranitidine, bronchodilators, injection hydrocortisone, also to prevent late effects of anaphylaxis. For neurotoxic bites, we give maximum of 20 vials of ASV. If there is further respiratory or respiratory muscle paralysis, we intubate and ventilate the patient. Also, if there is persistent local swelling with no worsening neurotoxicity or coagulopathy, that is not an indication to give further ASVs. So what is the role of antibiotics in wound management? So infection commonly occurs in cobra bites, especially due to unhygienic practices of incising the wound. They sometimes supply animal excreta and other contaminants. So antibiotics are administered only in cases of cellulitis or abscess formation, and most commonly used antibiotic in our setting is amoxicillin clavulanate. So this comes from 3 RCTs that have been done, which showed no role of prophylactic antibiotics to prevent infection. We also do surgical debridement, amputation, and skin grafting whenever necessary. However, we never had to do a fasciotomy in the last 3 years for a snake bite patient. So we have an excellent rehabilitation program And our rehab team, along with the psychiatry team, works at alleviating the long-term sequelae like amputation, chronic ulcers, contractures, scarring, wasting, depression, and PTSD that are associated with snakebite envenomation. I want to share with you the story of Kushi, who was a 10-year-old girl who came with an alleged cobra bite to our hospital. She had local swelling and necrosis. She was intubated in the emergency and was mechanically ventilated. She received around 20 vials of ASV. She was on tracheostomy for prolonged intubation. So even though her higher mental functions were normal, her pupils were dilated and non-reacting. So she developed quadriparesis with retrobulbar optic neuropathy. So 3 differentials that we were thinking of in this setting was probably a critical illness neuropathy that has set in. So or an immune-mediated neuropathy, either due to ASV or direct venom-induced neuropathy. So this neuropathy resolved in 3 weeks. However, she was found to have a T10 transverse myelitis with a T10 sensory and motor level. She had a bladder and bowel involvement, spasticity of the lower limbs. So at this point, we had advised her MRI, but she was unable to do it because of the financial constraints. So there was some evidence of giving injection methylprednisolone in some of the case reports from transverse myelitis due to viper bites. But we decided not to give methylprednisolone because MRI was not available and there was a risk of increasing infection. So our rehabilitation team took her over after acute management and they provided rehabilitation. They debrided, they did a split skin grafting. And after the end of her admission, she regained vision, bowel and bladder control, and was able to ambulate with support on discharge. So management of snakebite in Madhipura has its many challenges at different levels. So this is a prescription of a patient who has gone to 2 PHCs before they presented to us. So these PHCs were supposed to have ASVs, but however, patient received only ceftriaxone, dexamethasone, avil, hydrocortisone, and no ASV at all. Also, the second patient was gone to 2 different places, has received ASVs, but at a suboptimal doses of ASV. So what we do in such situation is we give balanced dose of ASVs at arrival in a hospital if there is clear documentation on how much ASVs has been administered previously. So in 13 PHCs in Madhipura are supposed to have ASVs. However, the availability depends a lot on supply from Patna, which is around 6 to 7 hours from these hospitals. And also other challenge that we face is most of the centers are not equipped with ventilators and or critical care support to take care of respiratory failure. Hence, a patient has to travel from one place to the other to get protocol-based treatment. So there are various challenges we face with ASV procurement and administration as well. So you can see in this graph, there is an increasing cost of ASV over the years. So it's a challenge as most of the people requiring ASVs are poor and marginalized. And in high demand season, you can see that ASVs are not easily available and ASVs are sold at a very high rate in black at a higher rate. So however, no patients are withheld treatment in our hospital due to lack of finances, and government schemes like Ayushman Bharat comes to aid in some patients. We face a lot of pyrogenic reactions with certain brands of ASV. However, by changing the brand of ASVs to a particular brand now, we hardly see pyrogenic reactions. Pyrogenic reactions are thought to occur because of the contamination during manufacturing. And with the use of adrenaline, as I mentioned earlier, there was anaphylactic reactions have reduced significantly. So some of the caveats in production of ASV also pose a threat, pose a challenge to the management of cases. So venom for ASV production is sourced from Irula snake catchers in Chennai and serves as a single geographical source for ASV in our country. So it has been found that there is quite a significant geographical variation in venom composition of species from South and North India. So hence administering antivenom made in South India might not be completely effective in neutralizing the antibodies that are produced by and venom that is produced by the snakes in North India. Also, the real need of ASV is not met as there is a weak health system and lack of reporting regarding snakebite envenomation and mortality due to snakebite. So it was demonstrated by these two studies published in 2005 and 2019, one by Mohamedra et al. And other by Suravira et al., that the real snakebite mortality is around 30 times higher than India's official figure. And this official figure is the one which drives the production of ASVs. Furthermore, inefficient distribution strategies and weak regulatory system make it very difficult for us to get safe, reliable ASVs, especially in high demand seasons. So another challenge that we see in our practice is gender inequity. This is a story of a 14-year-old girl who had presented to us from a very poor socioeconomic status, who came in respiratory arrest and was intubated in emergency, and she was admitted in ICU. However, after admission and talking about prognosis, the relatives wanted to go discharge against medical advice. And on inquiring why the reason for LAMA is, and we told them that we are fully willing to support the child. However, they were not willing to treat the child because this was a female child who was uneducated, and sometimes poverty drives them to prioritize which gender to treat. So also the family wanted to claim the grant by the government provided for snakebite victims. So what has been our response to address the problems of snakebite in our community? So there are three areas we work on. So first is to reduce the snake-human interaction, we provide awareness and public education. The community program focuses on all these areas that contribute to the cause of death, especially to decrease delay in presenting to the hospital and stressing on the futility of going to a traditional healer, which were, as I mentioned earlier, were the two major outcome determinant in our setting. As intervention to reduce mortality, training is given for healthcare professionals in and around Madhipura to follow protocolized treatment, stock adequate ASVs, and to refer the patient immediately if there is any respiratory failure, and if the patient needs a critical care or ventilatory support. So risk factors of snake-human interaction, as we've discussed earlier, cannot be easily alleviated because it's an outcome of poverty, and they hence can't be easily eliminated. So there are some challenges even in our prevention strategies. For example, in crate bites, we advise them to use mosquito nets to prevent snake bites in the night. However, because there are lack of beds in most of the houses to enable a well-tucked mosquito nets, this is not possible. This is a picture of picture brought to us by a snakebite victim, which shows a crate which has gone inside a mosquito net before biting the victim. So there are a number of community programs to empower communities through knowledge and practical interventions. So our community volunteers and home health aides from different villages are called to the hospital and offer training to spread awareness regarding snakebite prevention and first aid. So snakebite survivors are encouraged as peer educators to share their personal experience, to present to the hospital early, and to address the problem of going to the traditional healers. So to empower the coming generation, we have school visits where we do child-friendly illustrations regarding snakebite prevention and first aid. So all symptomatic and all asymptomatic and symptomatic patients who present to the hospital are given education regarding prevention and first aid during the hospital stay. So we also have a helpline number which they can contact in case of enquiry regarding snakebite. So there are some global initiatives WHO also has adapted to reduce mortality and disability related to snakebite envenomation. WHO has identified snakebite envenomation as a neglected tropical disease and is working to reduce mortality and disability by 50% by 2030. WHO has also convened a group of experts to make target product profile guidelines, which can be used by manufacturers, procurement agencies, clinicians, and researchers to improve design and development of ASVs. So guidelines are mainly made for animal-derived animal plasma-derived antivenoms, and engineered antibody therapeutics. And also they have working on newer therapies like small molecular inhibitor-based therapeutics that works against specific venom components like antiphospholipase A2 inhibitor, matrix metalloproteinase inhibitors, and aptamers, which can be used with ASV or probably as a pre-hospital aid before the patient reaches a hospital. However, these are being developed. They are also working towards improving access to high-quality ASVs made from geographically representative venom pool, which is suitable to be used in regions which they are marketed. They're also focusing on designing distribution pathways and systems to increase the availability at an equitably nominal cost so that poor families can also afford treatment. So multiple dose finding and clinical trials are underway to determine the adequate doses of ASV as well. So having discussed our management protocols, challenges, and strategies, I would like to end this presentation with these notes, especially for rural hospitals, which are located at a crucial point for snakebite victims. Equip a healthcare team, equip healthcare professionals and hospitals for snakebite care. Have safe transfer protocols in hospitals where critical care and ventilation is not possible. And community awareness regarding prevention and treatment of snakebite is key to reduce mortality. Snakebite mitigation can only be achieved if communities affected by snakebite are actively involved in its prevention. Thank you for your patient listening.
Thank you very much, Krupa, for that wonderful talk. We will now be taking a few questions. Krupa, can you hear us?
Yes, sir. I can hear you, sir. Can you hear me? Sir, I can hear you.
The first question that has been asked is there any evidence for using a low dose ASV protocol for purely neurotoxic snake bite?
According to the protocol, low dose ASV has been tried for hemotoxic bites. So low dose there are two protocols that we follow: low dose infusion protocol and high dose protocol. So in low dose protocol, what they do is after giving 10 vials of ASV, we can give 2 vials as an infusion every 6 hours till the coagulopathy resolves. This high dose and low dose has high dose was not proven to be better than low dose, so both were found to be of same benefit. But however, like in snakebite, there is one of the challenges that we have. The exact dose of how much to give is not done in any clinical trial. So that is something that WHO is trying to do. To prevent snakebite deaths and probably to decrease the cost of snakebite treatment.
Thank you. The second question is, what is the role of calcium gluconate in neurotoxic bites and how often do you use it?
So crate bites usually, in crate bites, because it's a presynaptic vesicle and the calcium is used as a neurotransmitter in presynaptically. In the protocol, the NHM advises the use of an IV calcium gluconate every 6 hours. But however, we generally don't practice giving IV calcium gluconate, but however, it's there in the protocol. The reason behind that is the presynaptic vesicle, the calcium is used as a neurotransmitter. But however, in our setting, we give only ASV and then intubate the patient if neuroparalysis sets in.
The other question is, Krupa, you mentioned that large majority or almost all patients who you receive at your hospital who are envenomed have neuroparalysis rather than hemotoxic envenoming. So, what proportion of patients who come to you have established neuroparalysis with features of respiratory failure requiring ventilatory support?
Yeah, I had mentioned in the presentation that around 13 patients out of 30 needed intubation, of which around 8 patients were crate and the rest were cobras. Around 13 intubations we had in the last year.
And what proportion of your cobra bites are associated with cytotoxic effects at the bite site requiring surgical interventions?
Around we had from 30 patients, around 14 to 15 patients were cobras. From the syndrome that we have identified, we identified the syndrome based on whether the patient has neurotoxicity plus local swelling. We take it as cobras. Most of the patients won't know which snakes have bitten them. In that, I can say that there are what indications of surgical management would be: we remove the necrosed tissue, debridement of the infected tissue, around tendon repair, and aspiration of abscess if the abscess has formed, and skin grafting. So around probably 50%, we delay our debridement for around 4 to 5 days, because there's a demarcation of necrosed tissue that happens in 4 to 5 days. So we don't do it in the initial phase where there is a lot of swelling. So probably 50% of our cobra bites will require removal of the necrosed tissue. Maybe around 25% might need debridement of the infected tissue, and 1 patient in the last year needed a tendon repair. And probably 2 patients around required aspiration of abscess, and skin graft also around 2 patients we did in the last year. But a lot of patients might not come back for a skin graft. They might let the wound heal with secondary intention. And there was no fasciotomy that we had to do in the last, in the last 3 years probably. We didn't have to do much of fasciotomy for snake bites, but we do limb elevation, maxillary dressing, and watch for compartment syndrome in patients.
Let's take one last question because of time constraints. You had shared a very important and relevant case of a child who had come with snakebite envenoming, who was discharged against advice. What exactly, if possible, was the reason? What were the reasons behind the family taking the patient away? Was a part of the reason the economic status, and how do you at your center actually, since you've presented that a vast majority of snakebite victims are extremely poor, how do you at your center actually address the issue of the socioeconomic status in seeking health care, especially in cases of sick patients who come to you with envenoming?
Yeah, all patients who come, regardless of the financial status, we admit them, and the ASVs are given regardless of money. If they come in with any neurotoxicity, we give ASV without taking a socioeconomic status background. But what we do for our patients is we do generate an Ayushman card for them if they don't have an Ayushman card. If they have a name in the ration card, we put their names in Ayushman. Even after admission, we try to make an Ayushman card for them. Another thing is, no patient is sent from a hospital because of the lack of finances. We give charity if they can't afford. And like whatever they can pay towards treatment, they pay and go. And be it even if they are in ICU or just requiring ASV. Also, for this patient who came, she came in respiratory arrest. We had intubated her, and we had put her in ICU. And after a discussion of the prognosis, the relatives wanted to take her home. Predominantly, I think they thought that the patient might not, because they don't know, like in the acute paralysis stage, we might think that patient is gone, but we see a lot of patients coming back. So this probably the relatives does not understand that and wanted to take her home, and they thought the patient had probably died. And they wanted to claim this grant by the government. But we had a big discussion with them, with the family, in our ICU, saying that we can fully support them if they don't have to worry about the money. But in spite of that, we see sometimes patients taking, relatives taking the patients home.
Thank you once again, Kripa, for that wonderful session. It's really heartening to see the work that Madhipura Christian Hospital is doing for snakebite patients. We will conclude this session, but if there are any other questions, I'm sure this can be then continued on the virtual platform. Thank you very much.